Every single year, doctors perform well over 2 million of these lumbar epidural steroid injections on Medicare patients alone. The standard clinical consensus treats these injections as a localized, temporizing measure for radicular back pain, a targeted burst of relief that stays exactly where the needle deposits it. Two massive retrospective analyses of MarketScan and Medicare claims data demonstrate this safety profile is incomplete. Looking at a cohort of over 720,000 documented procedures, the data reveals a different reality. At this sample size, rare physiological reactions stop looking like statistical noise. They map out predictable, systemic hazards originating from a supposedly local intervention. Standard monitoring for adverse events after an epidural injection heavily biases the immediate peri-procedural window, the first 7 days. Comparing complication rates over time, within the first 7 days, the rate is a low 2.5%.
Extended to 30 days, it climbs to 8.8%. This spike is heavily driven by medical complications, including a sharp rise in dysrhythmias and all-cause hospital readmissions. The physiological stress introduced into the body does not resolve when the needle is withdrawn. Instead, it compounds over the first month. The specific morphology of these complications is dictated by a mechanical choice, the anatomical approach the physician uses to reach the spine. This diagram shows the two primary injection routes. The interlaminar approach enters straight and relatively shallow, depositing medication into the epidural space from the midline. Because of its superficial angle, this approach carries a higher rate of immediate mechanical complications, like dural tears, during the procedure itself. The alternative is the transforaminal approach. Here, the needle is navigated far deeper, curving into the neural foramen near Camben's triangle to target the nerve root directly. This deeper penetration avoids early superficial trauma, but results in a higher risk of delayed procedural complications, specifically nerve root injury, manifesting well after the patient leaves the clinic. The proximity to the dense epidural vasculature also increases the risk of an epidural hematoma. If the patient is prescribed systemic pharmacology, this specific anatomical risk multiplies violently. Patients taking anticoagulants face odds ratios ranging from 3.70 to 5.71 for severe medical complications at 30 days. Choosing an injection approach involves a direct physical trade-off between immediate dural risks and delayed neurological or vascular hazards. Once the physical mechanics of the injection are complete, the patient's underlying metabolic state controls the complication timeline. Logistic regression models from the MarketScan dataset show that systemic organ health dictates the 30-day medical complication odds. The most intense risk multipliers center on heart failure and renal dysfunction. Renal dysfunction impairs the body's ability to clear drugs and maintain electrolyte stability, trapping the patient in a prolonged pharmacological exposure window. Heart failure carries the highest organic risk factor, with an odds ratio of nearly 3. In a compromised cardiovascular system, minor localized fluid shifts induced by the steroid trigger severe systemic decompensation. Because the intervention relies on the body to metabolize and clear the corticosteroid, systemic organ function is intrinsically tied to the localized procedural outcome. The definitive proof of this systemic penetration appears not at 30 days, but months later in bone density data. Clinicians universally monitor for bone loss when prescribing oral corticosteroids, yet there is a pronounced clinical blind spot regarding epidural absorption. The endocrinological mechanism is identical. Epidural steroid injections acutely suppress endogenous cortisol and serum markers of bone formation far beyond the spinal column. This plot visualizes data from a Medicare cohort of over 246,000 patients. Using high-dimensional propensity scores, researchers isolated the exact skeletal hazard of epidural steroid exposure against a baseline risk of 1.0. Following an injection, the data shows a hazard ratio of 1.39, a 39% increased risk for fractures at typical osteoporotic sites. For vertebral fracture specifically, that hazard ratio climbs to 1.69. The spine, the exact anatomical structure the injection is designed to treat, is the most vulnerable to systemic steroid-induced bone loss. This risk scales directly with cumulative exposure. Patients receiving 3 or more injections in a single year face an accelerated fracture risk within the first 6 months of follow-up. The epidural space is not permanently sequester corticosteroids.
A lumbar injection is a systemic pharmacological intervention with profound, measurable skeletal consequences. The data dismantles the assumption that an epidural steroid injection is a localized and temporary event. This matrix maps patient risk across a chronological continuum, requiring a new, evidence-based paradigm for treatment. Early procedural risks, like dural tears, plot at the origin, anatomical hazards confined to the first 7 days. Intermediate medical risks, dysrhythmias and hematomas, escalate into the systemic layer around the 30-day mark, and long-term skeletal hazards, including vertebral fractures, max out the systemic scale at 6 to 12 months. Evaluating a patient for an epidural injection can no longer end when the procedure is booked. Clinical practice must adapt to include 30-day medical monitoring for patients with cardiac comorbidities and long-term osteoporotic screening for those receiving multiple injections. In spinal interventions, a purely localized injection is a physiological illusion. Precision anatomy commands a systemic price.